We are live now, ma'am.
Thank you.
Yeah. Good evening, esteemed faculty members and all the delegates. Thank you for joining. This is Sahiti on behalf of Shield Connect. Welcome you all for today's webinar, Significance of Nutrition in Midlife and Beyond, organized by Chennai Menopause Society. So it's my privilege to introduce the MOC of today's webinar, Dr. Meena Mahalingam, ma'am. Ma'am is the Associate Professor in Obstetrics and Gynecology in Chengalpat Medical College and also Secretary of OXY, Co-Chair of Urogyne Committee OXY and also member of Urogyne Committee Subcommittee FOXY. I welcome you, ma'am, and I hand over the session to you.
Thank you, Sahiti. Now I would like to introduce our President, Madam, President IMS. Can you please share the CV? Shanti Gunasingh, ma'am, Consultant in Obstetrics and Gynecology, Mangalam Healthcare, Chennai, President, Chennai Menopause Society, past President OXY, former Director and Superintendent, Institute of Obstetrics and Gynecology, ISO KGH, former HOD of OG, Kilpauk Medical College, served as Project Director, Center of Excellence for Tubal Microsurgery for 6 years, past President, Women Doctors Association, Tamil Nadu. Master Trainer for BMONG, CMONG, SPA, Tubal Microsurgery, Lactation Management, Adolescent Health, Continuing Adolescent Health Care Programs. Like to hand over the session for Madam's introduction. Welcome, Anita, ma'am. Madam, can we go ahead and have...
Yeah. Good evening, one and all. We are gathered here for the 20th webinar by Team for CMS 2023 to 25. A well-balanced diet is crucial for midlife and beyond women for maintaining health and preventing chronic diseases. Hence, this webinar on nutrition and menopause. I am extremely happy to welcome Dr. Anita Shah, our dynamic president of Indian Menopause Society, who really, in spite of her busy schedule, she had just now delivered a talk in IMS webinar, and she has graciously consented to join us and also release our Model 20, Menopause Associated Disorders Awareness Letter. And I'm very happy to have Dr. Cynthia Alexander, one of the senior CMCNs who's always with us to encourage us. Madam's smile and enthusiasm is infectious. We are indeed proud to have such senior CMCNs to guide us. Happy to welcome all the accomplished chairpersons and erudite speakers. Special welcome to Dr. Pal Manikam, who will be joining us in spite of it being dawn in US. I greatly appreciate his passion for dissemination of knowledge laced with much humor for the betterment of mankind. I am really very happy to welcome all the delegates who have joined us in spite of this being prime practice time because of their passion to treat our midlife and beyond women appropriately. So welcome one and all.
Thank you, Madam, for the presidential address. Now I would like to start the function with our Tamil Thai Valthu. Thank you, Sahiti. It gives immense pleasure to introduce our energetic secretary, Dr. Meera V.V. Raghavan, consultant urogynecologist and robotic surgeon, affiliated to Apollo Hospitals, Chennai and Specialty Clinic. She is a board certified lifestyle medicine physician, national board specialist committee member, national board coordinator and examiner, MRCOG trainer and examiner, fellow representative in South Zone IRC, RCOG, Secretary Chennai Menopause Society, Apollo Simulation Center Coordinator and Director for Obstetric Skills Course. She has won 32 gold medals in undergraduate curriculum and best outgoing PG student in PGI Chandigarh. Over to you, Meera ma'am, for CMS prayer. Sorry.
We pray to God to give us grace to accept the midlife physical challenges and gently renew our strength. Guide our heart, our mind and body to navigate the way, and our trust in you to lead us safely through. We pray for midlife and mature women who cherish the fond moments of their life, and also for those sitting in a doctor's office or who are in bed asking for healing touch. On this day, may all the midlife and menopausal women have the gift of joy, hope, and good health. Thank you, God, for the promise of hope you hold out to all midlife and menopausal women and inspire us to give this gift of hope to others.
Thank you, Meera ma'am. Now we would start the auspicious function, the 20th CMS webinar, by lighting the Kuttuvilakku. Now request President Madam to introduce Anita Shah ma'am, IMS President, and request her to felicitate our CMS webinar. Over to President Madam.
Yeah, thank you very much,
I have
dear
great
Dr. Min.
in introducing Dr. Anita Shah, practicing gynecologist in Surat since 1988, president of IMS, president of Surat OG Society in 2000-2001, when it received the Best Society Trophy from Foxy, organizing chairperson of World Conference on Population Stabilization, February 2003, and organizing secretary of National Conference of IMS in Surat in 2009, president of Udna Medical Association, and she is also
Shantiji will do. It will do.
involved with IMA and has received a lot of awards too. Welcome, to our webinar.
Yeah. Thank you very much, dear Dr. Santiji, for your kind words and for inviting me over here for your this webinar. I know that Chennai Society is very, very active. A lot many keen academicians are there in your society, and you are working a lot. I had been to Chennai years back when there was a zonal conference at Chennai, and Jaishri Gajaraj was, I think, at that time the chapter secretary of Chennai. So of course at that time my son was in perhaps 12th standard, so I had come for one day only, but I had enjoyed that. So I do remember Chennai in that way. So first of all, heartiest congratulations to all of you for this webinar. The topic is very, very special because nutrition plays a keen role in the health of a woman. And I'm sure at the end of the webinar, a lot many carry home messages you will be able to give to all the listeners. So I think without wasting any time, I just would like again thanks a lot to all of you and all the best for this webinar.
Madam, I would request you to release our 20th edition of e-newsletter, Model 20.
Okay. Okay. Yeah, sure. So, heartiest congratulations for this lovely e-newsletter. I'm sure it will have a lot of inputs by all of your esteemed members. I'll also would like to go through it, and I'm sure I will also enjoy it. So again, heartiest congratulations.
Thank you, Madam. Thank you for your wishes. It was indeed a pleasure to have you with us, Madam. Thank you.
Yeah.
Request President Madam to invite our guest of honor, Cynthia Alexander Madam.
Yeah, Madam is one of our own, and it is indeed my pleasure to invite all these stalwarts. And we are really very happy and proud to have Madam here as guest of honor. She's a former director in IOG and former professor and HOD of OBGYN Madras Medical College, and had a long government service for about 35 years, awarded Lifetime Achievement Award from Tamil Nadu MGR Medical University, Dipsy, Times of India and Economics Times Award, New Delhi, 2018. Cynthia, Madam, please.
All right. Thank you, Shanti. Good evening, Anita, if you're still online. And good evening to all my friends viewing this webinar. I thank the president of Chennai Menopause Society, the secretary, and all the other office bearers for this honor given to me to be the guest of honor. And I was very happy because just imagine I'm sharing the screen with Dr. Pal. I enjoy his views and his talks. Even yesterday I saw about Dolo 650 and I laughed and laughed. So I'm very happy that I'm sharing the screen with him. Now coming to this webinar, of late, menopause awareness is touching new heights. Acceptance, education, empowerment, empathy, and even the government is giving a lot of support to improve the status of midlife and menopausal women. In the recent edition in The Hindu, there were nice 3 articles and about menopause. And statistics shows that with increasing longevity, almost 1/3 of women live in their menopausal age. So it is very important that they must have a quality of life. And the CMS, that is the Chennai Menopause Society, has played a great role in educating women, not only in the physical aspect, but also in the emotional, spiritual, and nutritional aspects. And this day, the program is all about nutrition in midlife and menopause. A famous doctor, Dr. Oxy, he was a famous nutritionist, will always say, we are what we eat. We are what we eat. So we should concentrate on our diet, on taking care of our bone health, sarcopenia, which occurs in menopause, skin health, and mental health. I recently saw an advertisement in a eatery unit, which read, we serve nutritious food for women who served society and their homes. And the age limit, it was written that the age limit is above 50 and above. So I felt very happy that the world is becoming very conscious of menopausal women. And certain homes, especially where children have gone to seek greener pastures and this empty nest syndrome, which we read about, it is very important that we must take care of ourselves, take care of your nutrition and health, and you are precious because we are precious to the world. And like me, I am almost, enjoying my 36th year after menopause. So this is to show how well I looked after myself. So this is a message that I give all my younger friends. Take care of your health. You are needed for your home, for your society, everywhere. So we are going to listen to a bountiful talk today on this. So thank you very much.
Thank you, madam, for your wonderful speech as usual, madam. It is really a pleasure to hear you.
Thank you, Shanti. Okay.
Thank you.
Thank you, President ma'am, Anita ma'am, Cynthia ma'am. Now let us move on to the session. First session, I would like to introduce our chairpersons, Dr. Nandita A. Thakur ma'am, who is the Medical Director of Nandita's Fertility and Research Center, Chennai, Academic Head and Coordinator, Senior Consultant at Mehta Hospital, Chennai. Her areas of interest are reproductive medicine, high-risk pregnancy. She has got a great passion for UG and PG teaching, and she runs a Telegram group as well. Focus training programs, skill training, workshops, and design teaching modules. Presented papers at national and international conferences. And Dr. Geeta ma'am, who has done her MBBS in Tanjavur Medical College, PG Diploma in Ultrasonography from Annamalai University, MHC Diabetology from Annamalai, practicing sonologist since 2002, Women and Diabetic Healthcare Clinic, Lakshana Scan Center, MKB Nagar, and has a great passion in Bharatanatyam. Over to the chairpersons to take over the session and introduce the speakers of the first session. Over to you, chairpersons. Thank you.
Thank you, Dr. Shanti and Meera, for giving us this opportunity to chair this session. Our first speaker is Dr. Aditi. She's a consultant at the Department of Internal Medicine at Mehta Specialty Hospital, and she's a faculty General Medicine RWA online medical education portal. And I would say she's a little walking Harrison for our hospital, always ready to help us. And she's won many prizes, of which the first prize in the Young Investigator Award session at the World Hypertension Congress. We welcome you, Dr. Aditi, to speak on common nutritional disorders in postmenopausal women.
Thank you for your kind words, ma'am. At the outset, I'd like to thank the Chennai Menopause Society for having me present this talk today. I hope my screen is visible and I hope I'm audible as well.
Yeah, you're audible.
Yes, madam, you're audible. Your screen is visible. Can you make it a slide share?
Yeah.
Yes, madam. Thank you.
Feel well, Aditi.
Thank you. So I'd also like to thank the Chennai Menopausal Society for choosing this extremely relevant topic. So as we're able to see, nutritional deficiencies contribute in a big manner to the global disease burden. So although over the past 3 decades, we've been trying to reduce this burden of nutritional deficiencies. In contrast, the market size for the nutritional supplements seems to be ever increasing. And with all the information that's just a click away, I think it's very important for us as the healthcare providers to be aware of what the right amount is, what the optimum nutrition is, because that's going to be the medicine of tomorrow. So in that sense, I really think this is an extremely relevant topic. And considering the increase in the life expectancy, most women are going to be spending at least 40% of their lifetime in the postmenopausal period. So I think it's a very, very relevant topic for today. And I'm going to be spending the next few minutes touching upon some of the commonly encountered nutritional problems in the postmenopausal women. So I'm going to be focusing on the big 3 nutritional problems, which is anemia, B12 deficiency, and osteomalacia. I'm also going to be talking a little bit about the micronutrient deficiencies that are commonly encountered in the postmenopausal age group. So we'll start out with anemia. I'm sure all of you are aware that anemia is the most commonly encountered nutritional problem across the world, across age groups, across borders. So anemia in women again is very, very important. In women, the most common
type of anemia is going to be the iron deficiency anemia, and this is followed by the anemia of chronic disease. Is this true in the postmenopausal group as well? That is what we're going to see. So first of all, is anemia common in postmenopausal women? Is this large contribution from iron deficiency anemia common in postmenopausal women? If you think iron deficiency anemia is still the most common type of anemia in postmenopausal women, I'd like you all to raise your hands. I think that works on Zoom. If the participants could raise their hands, whoever agree with the question, I think it would contribute to some amount of interaction on Zoom. So the answer is that with age, we all know the iron requirement actually increases up to a certain point. And in the postmenopausal age group, because of absence of the menstrual blood loss, the iron requirement actually comes down. And that's the reason anemia is not as common in the postmenopausal group as it is in the premenopausal group. The prevalence of anemia in postmenopausal women, as determined by a small study done in India, was as high as 85.2%. Further on, they found that there was an age-associated increase in prevalence, with the prevalence of anemia doubling with every decade. So anemia in postmenopausal women, again, although it's not as common as in premenopausal group, the most common type of anemia is still going to be the iron deficiency anemia. So WHO defines anemia as hemoglobin level of less than 12 gram per deciliter, and that stays good for the postmenopausal group as well. Now, the contributory factors to anemia in the postmenopausal group predominantly include either dietary inadequacy or blood loss. So it's usually going to be one of these two. And blood loss can occur from something as trivial as a diverticular bleed or a hemorrhoid, or something more concerning like a malignancy. Dietary inadequacy, again, is a very common cause of anemia in the postmenopausal group. Another important cause for a lot of nutritional disorders in postmenopausal older women is going to be polypharmacy. A lot of drugs that they take in is going to significantly alter the bioavailability and the absorption rates of the various nutrients and micronutrients that are going to be present in our diet. So that also plays a major role in bringing about anemia. Further on, there's going to be an increase in the comorbidities as the age progresses, and therefore presence of chronic diseases in the postmenopausal age group, presence of renal insufficiency, all these are also going to contribute to anemia. Although the most common type of anemia in postmenopausal women is going to be iron deficiency anemia, by and large, in the elderly age group above 70 years, the most common cause for anemia is going to be the anemia of chronic inflammation. Now, coming to clinical features, typical presentation, I'm sure all of us are already familiar with. Most often, iron deficiency anemia is going to present with fatigue and effort intolerance, whereas B12 deficiency presents with cognitive impairment and unsteadiness because of the sensory ataxia. But in the postmenopausal group, we can have atypical presentations like dementia, depression, and even decreased performance, which is something that we should watch out for in this group. Also, anemic females are more likely to have a lower BMI, which is body mass index, and also they're more likely to have a lower BMD, which is bone mineral density. So you have somebody who comes to you with osteoporosis, lower T scores, reflecting lower BMD, or somebody who is very, very lean in their postmenopausal stage. Keep in mind that they could be anemic. So workup for anemia in the postmenopausal group still largely remains the same as how we would work up anemia in any other group. So we're going to look at the RBC indices, the MCV, MCH, and the MCHC to determine whether it is microcytic, normocytic, or macrocytic. Iron indices, again, very helpful in determining if we are looking at an iron deficiency anemia. B12 folic acid levels, again, very important. Peripheral smear and motion occult blood. So this is something that we would generally do as the battery of tests whenever we encounter any patient with anemia in the postmenopausal group as well. Now, based on the RBC indices, we all know when we have a microcytic anemia in this group, the most important thing that we're going to think about is going to be the iron deficiency anemia. In the same way, if we have a macrocytic anemia, most important cause is going to be B12 deficiency anemia. And when we have a normocytic anemia, this could be either hemolysis or blood loss, and stool occult blood plays a very important role in determining if there is a GI blood loss or not. Now, as I said, when there is a microcytic hypochromic anemia on the peripheral smear, the most important cause is going to be iron deficiency anemia, which is defined by a serum ferritin level of less than 15 microgram per liter. Now, serum ferritin is the single most sensitive test. So even if you're in a resource constrained setting, the best test to do to determine iron deficiency anemia is going to be a serum ferritin level. But what is the flip side to this dictum? The flip side is that ferritin is an acute phase reactant. So if your patient is in a phase of an acute illness or in a state of acute inflammation, you may be misled by your serum ferritin, which may be falsely high. So keep that in mind. In addition, in your patient with iron deficiency anemia, usually the serum iron is going to be reduced, serum transferrin saturation is going to be low, but serum total iron binding capacity is going to be elevated. And when you have an iron deficiency anemia in a postmenopausal woman, as I said, two major causes: dietary insufficiency, or it is going to be either nutritional deficiency, or it is going to be blood loss. Most important blood loss is GI blood loss. So stool local blood test is very, very important in this group. It has a sensitivity of 73% and a specificity of only 23%. So generally, we look at tests with good sensitivity as being good screening tools, because they're going to help us in ruling out a problem. So this can rule out a GI bleed by 73%, and hence is very, very important. Therefore, if your stool local blood is going to be positive, we are going to go ahead with scopies and evaluate further. If it is negative, then we will have to evaluate for other causes, look for nutritional deficiency, replace iron, check if B12, folic acid is replete. If not, replace them as well. So iron deficiency anemia in the postmenopausal woman, how are you going to replace this iron? The problem with oral iron is that there's going to be a lot of constipation. In this group, constipation is going to be a huge problem, because with age, the bowel motility comes down, fiber intake comes down, fluid intake comes down, and that is the reason why constipation increases in incidence. So you do not want to compound a problem which is already present. Therefore, the more preferred formulation in this group is going to be IV iron. So we have ferric carboxymaltose, which is given as a 500 to 750 milligram per dose. Usually we give 2 doses at 1 week apart, and we make sure that we do not exceed a cumulative dose of 1500 milligram over a 2-week period. Now, if you cannot give parenteral iron, if there is no constipation, no GI issues, you can go ahead with oral iron as well. A few pointers with oral iron that I would like you to remember. Number one, remember that once daily dosing is as good as twice daily or thrice daily dosing. Sometimes I find the lower the hemoglobin, more the daily doses of iron is, but studies have clearly shown that the bioavailability of iron is as good with a once daily dosing as a twice daily or a thrice daily dosing. So once daily dosing is what is preferred. Two, as far as the formulation of iron goes, ferric ascorbate or ferric glycinate is actually better because it has better bioavailability than ferric sulfate. Newer iron, which is this ferric pyrophosphate, which is available in the market as Ferrizone, is better tolerated. And keep in mind, whenever you're offering oral iron for the patient, ask them to avoid taking it along with milk, calcium supplements, or antacids. Also, keep in mind to advocate them to take in all these iron-rich foodstuffs. Generally, I advise my patient to take in a lot of greens and nuts if they're going to be having iron deficiency. Now, let's move on to the next important nutritional disorder, which is B12 and folic acid deficiency. We know that in older age group, not just in the postmenopausal women, even in males, B12 folic acid deficiency contributes in a significant way to falls and to cognitive impairment, and therefore this is something that should be watched out for in the older age group. So B12 deficiency in postmenopausal women, is it common? The answer is yes. It is seen in at least 1 out of every 5 postmenopausal women. What are the contributory factors in this group? So in this group, again, drug intake plays a very important role. As most of you would have already encountered, a lot of the older patients are on long-term antacids or proton pump inhibitors, which is going to reduce the absorption of B12. So long-term intake of PPIs and H2 blockers can reduce the B12 absorption. Then atrophic gastritis, bowel resection. If you have an older patient who's undergone a bowel resection, all this is going to contribute to B12 deficiency. And this can result in dementia, in neuropathy, in cognitive impairment, and in falls. Now, it is shown by several studies that B12 and folic acid supplementation improves cognitive function in the postmenopausal women. It reduces homocysteine levels, and it reduces ASCVD risk, and also reduces dementia. Now, how do we manage B12 deficiency? So when B12 levels are going to be less than 100 nanogram per ml, then the patient is said to have B12 deficiency. Different labs have different cutoff limits, but generally this is the cutoff limit that we use. For folic acid, the cutoff is going to be at 2 microgram per liter. when you have a patient with B12 deficiency, so we generally give B12 as a weekly injection, weekly intramuscular injection at a dose of 1000 micrograms for 6 weeks. This is then followed by maintenance injections, which are given once in 1 to 3 months. So if you're opting for a methylcobalamin regimen, it will be once a month. If it's a cyanocobalamin regimen, it will be once in 3 months. Then folic acid deficiency, folic acid replacement happens through doses of 5 to 15 milligram per day, depending on the GI absorption. For those with a normal gut, no other malabsorption syndromes, 5 milligrams daily dose would suffice, and this is generally given for at least a 6-month period. And in addition, we of course ask patients to increase the intake of all the B12 rich foodstuffs. This is going to be a big problem, particularly in patients who are following a strictly vegetarian or a vegan diet. But even in such patients, intake of fortified cereals, mushrooms, and eggs will make a difference. Moving on to the next important nutritional disorder for discussion, which is osteomalacia. Now, what is osteomalacia? How many of you think it is the same as osteoporosis? By show of hands, is osteomalacia the same as osteoporosis? I'm not able to see the hands here. I think there's a show of hands button, so the participants can actually click on the hands or maybe put on the chat box as to what they think. It will be a good way to have some sort of an interaction in the Zoom session. So how many of you think osteomalacia is the same as osteoporosis? Not same. So most of you are convinced that it's not same. But can osteomalacia increase the risk of osteoporosis? A simple yes or no on the chat box. Yes. So osteomalacia is not the same as osteoporosis, because osteomalacia actually is something that refers to bone mineralization. There is going to be a defect in the bone mineralization. There's going to be an alteration in the bone mineral to matrix ratio. Whereas osteoporosis, we all know. How do we diagnose osteoporosis? Simply by asking the patient to get a bone mineral density scan. So if the bone mineral density score is low, if the bone mineral density is low, that means the patient has osteoporosis. So both are two different conditions. Osteomalacia is a defect in the bone mineralization, and the most common cause for osteomalacia is going to be vitamin D deficiency. So again, for vitamin D deficiency, this is something that I've seen across several reports that my patients bring to me. So different labs have different cutoffs, but this is what is widely used. The Endocrine Society, it uses 20 nanogram per ml as the cutoff for deficiency and 30 nanogram per ml as a cutoff for insufficiency. So generally, we treat patients for vitamin D deficiency when their levels are going to be under 20 nanogram per ml. If it's less than 10 nanogram per ml, then the patient is said to have a severe vitamin D deficiency, and generally we target only a vitamin D level of up to 30 nanogram per ml, no more than that, because studies have shown that there is no improvement in fall risk or in the risk of fragility fractures as you keep increasing the vitamin D levels beyond 30. Further on, as the vitamin D levels increase further, there is a counterproductive effect on bone health as well, and you wouldn't want that. So looking at vitamin D deficiency in postmenopausal women, like we saw with B12, here again, 1 out of every 5 women can have vitamin D deficiency. What are the contributory factors which are particularly unique to the postmenopausal group? So with age, what happens? The thickness of the skin becomes lesser and lesser. So because of thin skin, there is going to be a reduced ability to actually synthesize the vitamin D. We all know skin is the site of synthesis for vitamin D. Not only that, because of reduced mobility and a largely sedentary lifestyle, which is going to be had by most of the women in the postmenopausal group, there's going to be lesser exposure to sunlight. And with age, there is going to be reduced absorption from the gut, reduced hydroxylation because of reduced enzymes being available in the liver as well as in the kidney. So all of this collectively together results in vitamin D deficiency in the postmenopausal women, and that contributes to osteomalacia, which in turn contributes to osteoporosis, fragility, fractures, falls, and also cognitive dysfunction. So as I said, osteomalacia is something that is seen because of decreased bone mineralization, whereas osteoporosis is something that is seen because of reduction in the bone mineral density. The one thing that's common to both is that both are associated with fragility fractures, and osteomalacia itself is a risk factor for osteoporosis. Remember, more than 50% of postmenopausal women tend to have at least one osteoporotic fracture in their lifetime, whereas osteomalacia is something that is seen only in 20% of postmenopausal women. So that again brings me to the next important question: is routine vitamin D supplementation required for all women in the postmenopausal group? Again, a show of hands or a simple yes no in the chat box, either would suffice. So everybody says, most say it's no. So that is the right answer. So actually, routine vitamin D supplementation is not recommended, especially if the patient is going to be under 75 years of age. However, above 75 years of age, empirical vitamin D supplements have shown to make a difference both in the bone health as well as in the cognitive function. Therefore, a low dose daily vitamin D supplement is something that is recommended in postmenopausal women above 75 years. But below 75 years, routine vitamin D supplementation is not recommended. What is the dose of this routine daily vitamin D supplement? It is going to be 800 units per day. Now, although studies have looked at higher doses also, up to 3000 units per day has been safe. Now, routine vitamin D screening, again, is this required? The answer is that routine vitamin D screening is generally not required in the postmenopausal age group. But when you have an older woman above 65 years of age, or if the patient has additional risk factors like any chronic comorbidities, CKD, CLD, malnutrition, obesity, sedentary lifestyle, reduced exposure to sunlight, any of these risk factors present or increase in the age requires vitamin D screening. Otherwise, routinely for all postmenopausal women, we need not do a vitamin D level. Now, this brings us to management of vitamin D deficiency in postmenopausal women. So, actually, in 2019, there was this meta-analysis which looked at different studies across the world, which have studied at the different doses which work better in postmenopausal women, and this particular meta-analysis agreed on a daily maintenance dose of 2000 units per day for betterment in both bone health and in cognitive function. They also found from most of the studies that a single 6 lakh unit intramuscular dose is something that is more effective than the daily maintenance dose, particularly when patients have a severe vitamin D deficiency. I'm sure most of you would have seen certain doctors prescribe a single intramuscular start dose of 6 lakh units. So this is available as an injection arachital. And this is something that's preferred when you have a postmenopausal woman with severe vitamin D deficiency, and severe vitamin D deficiency being vitamin D levels of less than 10. And whenever you treat, you only target a vitamin D level of 30. Once the vitamin D reaches 30, the patient does not require any further replacement doses. However, maintenance doses still need to be continued. Now, on that note, the recommended dietary allowance in postmenopausal women varies between 600 to 800 units. If the age is going to be less than 70, it's 600 units. More than 70, it's going to be 800 units. So in 2019, again, the American Association of Clinical Endocrinologists, they came up with their own guideline, and they said when a patient is diagnosed with vitamin D deficiency, then we need to treat the patient with either 6,000 units per day or with a 50,000 units per week. I think most of you would be familiar with the weekly doses. Most of us, we tend to prescribe patients with vitamin D deficiency with these weekly doses of vitamin D because they're more convenient. Now, and most of the tablets that we have in the market come as a 2000 unit, 2000 international unit per tablet. So that would mean the patient would have to take at least 3 tablets a day, which makes it very inconvenient. That is the reason we generally opt for weekly doses of 50 to 60,000 units. And this is generally recommended for 8-week period. So this is how we would treat vitamin D deficiency with a 50 to 60,000 unit tablet once a week for 8 weeks, and subsequently this is followed by your daily doses of 2000 units per day. Now, if the patient has other risk factors, for instance, if the patient has a chronic kidney disease or a malabsorption syndrome, then we can even increase the daily dose up to 10,000 units per day. And as I said, if your patient has a severe vitamin D deficiency, a more effective option would be to give a single intramuscular dose of 6 lakh units and recheck your vitamin D levels after about 12 weeks. These are some of the foodstuffs which are rich in vitamin D. So as you're able to see, again here, most are going to belong to the most of these foodstuffs are not encountered in your vegan or vegetarian diet, and hence those would be the patients who are going to suffer the most from these nutritional disorders. Now, having completed the big three, a little bit on the micronutrient deficiencies, I'm going to be talking about magnesium, calcium, and omega-3 fatty acids. All three are very important, very relevant, particularly in the postmenopausal women. We'll see why. Now, magnesium deficiency in the postmenopausal women, contributory factors include the fact that there is going to be reduced absorption from the gut, which is something that exists for most of the micronutrients. Dietary inadequacy, again common for all micronutrients. Consumption of processed foods is something that is going to sort of decrease the magnesium intake, because magnesium is largely present in naturally available foodstuffs, in most of your green leafy vegetables and stuffs. Therefore, when your patient has a tendency to consume a lot of processed foods, then there's going to be an increased risk of magnesium deficiency. Also, in older women, there's going to be an increased magnesium loss both through urine and sweat, which has been determined through studies. And again, whenever you're looking at nutritional deficiencies in the postmenopausal group, remember their polypharmacy, their drug intake is going to play an important role in altering the bioavailability of these micronutrients. Therefore, drugs like diuretics, PPIs, H2 blockers, antacids, antihistamines, all these commonly used drugs are going to result in magnesium deficiency. Magnesium deficiency is very prevalent in postmenopausal women. Many studies say that the rates vary between 10 to 40%. Now, impact of magnesium deficiency. Now, most often you would have women coming to you with acroparesthesias, cramps, myalgias, depression. Magnesium can also result in decreased bone mineral density. It can reduce the vitamin D actions, and can also reduce the level of calcium and thereby contribute to osteoporosis. It also increases the incidence of vasomotor symptoms in postmenopausal women, also increases your glycemic levels and the blood pressure levels, and increases ASCVD risks and anemia. So magnesium is very, very important. One of the most common symptoms that most older patients come to us is going to be with these cramps and acroparesthesias, which is when we should consider the possibility of magnesium deficiency. So as I said, in addition, it can also result in reduced vitamin D and calcium level, and also contribute to osteoporosis. Now, magnesium supplementation decreases the risk of osteoporosis. It decreases the risk of these vasomotor symptoms in postmenopausal group. It improves diabetic control, improves blood pressure control, reduces CVD risk, particularly in the postmenopausal group. And it is recommended at a dose of 400 milligram per day. So when you have a patient with magnesium deficiency, 400 milligram per day is what has been studied, and this is generally prescribed for a 3-month period, but you can go on giving the patient up to 12-month period in case the patient stands at risk for ongoing magnesium deficiency. The recommended dietary allowance is going to be 310 to 320 milligram per day. So usually the recommended dietary allowance in women is around 300 milligram per day, in men is going to be 400 milligram per day. And this daily magnesium supplements is something that has to be considered, particularly in patients with either contributory factors, which is what we saw, intake of any of these medications which could interact with magnesium absorption, or in patients who do have symptoms like cramps, vasomotor symptoms, and acral paresthesias. These are some of the magnesium rich foodstuffs. So off the top of my head, lot of nuts, lot of greens is going to take care of your magnesium. Now, coming to the calcium deficiency in the postmenopausal women, contributory factors again include dietary inadequacy, reduced absorption, and the fact that there is an increased risk of vitamin D deficiency and magnesium deficiency. All these are going to contribute to calcium deficiency in postmenopausal women. Again, drugs like diuretics, anti-epileptic drugs, steroids, proton pump inhibitors, all of them are also going to interact with calcium absorption. It was found from studies that at least 75% of women have dietary calcium deficiency, and that is why calcium supplements are very important in the postmenopausal group, because calcium deficiency can result in osteoporosis, can increase the risk of fragility fractures as well. But the problem with calcium is that you should know where to draw the line. So it has been shown that there are risks associated with excessive calcium intake in the form of renal stones, cardiovascular risk, and fractures as well. So usually this happens with daily doses of more than 2 grams per day. Generally, we look at daily doses of 500 milligrams to 1 gram per day. So calcium supplementation in postmenopausal women, it does increase the risk of osteoporosis. It is indicated in vitamin D deficiency and particularly in postmenopausal women with fractures. The recommended dietary allowance is 800 to 1200 milligram per day. 1200 milligram per day is what is recommended as the calcium requirement on a daily basis. Now, what happens is that most of us would have at least two of these foodstuffs in a day, right? At least a glass of milk and any one of these other, servings, or at least two glasses of milk, which is going to make up at least 500 milligrams from our diet. And therefore, we generally put our postmenopausal women on a 500 milligrams per day of calcium. If there is going to be risk for further dietary inadequacy, then we are justified in putting them on 1 gram per day of calcium.
Aditi, can I just ask you to finish? We are a
Yes,
little
ma'am.
overshooting.
Yeah, I'm almost done. So moving on to the omega-3 fatty acid deficiency in postmenopausal women, here some of our contributory factors include decline in estrogen levels, which will affect the availability of these omega-3 fatty acids. And the impact is that it increases the vasomotor symptoms, insomnia, depression, and dry and flaky skin, also contributes to joint pain. So omega-3 fatty acids in postmenopausal group, it does improve sleep, vasomotor symptoms, it improves depression, improves cholesterol levels, and the recommended dietary allowance, although it is at 1.2 gram, the generally recommended dose is 1 to 2 gram per day. So patients with a lot of insomnia, depression, and cognitive impairment, or one of these symptoms like dry skin, will benefit from omega-3 supplementation as well. So before I wrap up my talk, it's unfair if I don't address the elephant in the room, which is obesity. So we all know obesity is extremely prevalent in the postmenopausal group. We all are aware of the different risks which come from obesity and the options that exist for obesity as well, from eating right to moving around to all the drugs that we currently have in the market to bariatric surgery. And this is again something that we should watch out for. So as I finish, I'd just like to give you 5 important tests that you should watch out for in your postmenopausal woman to pick up these nutritional disorders. Number 1 is going to be hemoglobin. We just saw that anemia is very, very common in the postmenopausal women. Number 2 is going to be HbA1c, particularly important when you have a woman who is also going to be obese with other features of metabolic syndrome. 3 and 4 are going to be calcium and magnesium, 2 frequently encountered micronutrient deficiencies, and 5 is going to be your vitamin D, particularly important when you're dealing with older postmenopausal women or in a postmenopausal woman with a lot of comorbidities. So remember, every meal is an investment. So don't just look at the short-term goals. Motivate your patients to look at the long-term goals and encourage them in eating right, because essentially we are at the end of the day what we eat, as ma'am rightly pointed out. Thank you. Sorry if I took a little more time than what was given to me. Thank you.
Thank you, Dr. Aditi. That was a very wonderful presentation. Dr. Geeta.
Yes, ma'am.
Request Geeta ma'am to introduce the next speaker.
Yeah, can you just show the screen, ma'am?
Please share the CV.
Screen.
Meera madam.
It's been shared already. So
Yeah.
we'll go ahead.
We welcome Dr. Meera Raghavan once again. She's our secretary of Chennai Menopause Society. She's a consultant urogynecologist and robotic surgeon. And
Geeta ma'am, we'll go ahead because it's been shared already.
Happy to have you and
thank you, ma'am.
Enjoy the talk.
Thank you. There might be some overlap between Dr. Aditi's fantastic recap on all the micronutrients, the nutritional disorder. Nevertheless, this will be a reiteration of what is important and also what we need to take forward as take-home messages. And thank you for the opportunity to be here yet again. So micronutrients in midlife, menopause, and beyond. We all know the various stages of menopause, starting with the pre-menopause, coming to menopause and post-menopause. This is basically a decline of the hormones. And perimenopause can begin well a decade beforehand, before the actual onset of menopause. And the rest of the life is spent actually in the nadir of the hormones, which goes to say a lot about women's health, which can happen after the decline of the hormones, especially decreased estrogen, progesterone, and testosterone, and an imbalance in the thyroid levels along with cortisol and the insulin fighting against each other. Hence, the overt diabetic state or the pre-diabetic state, a postmenopausal women or a perimenopausal women can be a candidate for. The impact of menopause on health itself can be on various systems from top to toe, with an accelerated bone loss and increased osteoporotic risk, which itself is a silent pandemic. Higher cardiovascular disease. In fact, nowadays we're seeing women with almost complete coronary blocks, much more than men in a decade earlier. And vasomotor symptoms are, in fact, a warning sign of possible severity of the cardiovascular or end organ problems. Higher the incidence or higher the severity of vasomotor symptoms, it could be a harbinger of the severity of the cardiovascular morbidity a woman can be exposed to. Along with comes the cognitive changes like memory, concentration, and mood disturbance. It is now called the third diabetes. The D, the dementia word, is a big nightmare, mostly in the Western country because of the aging population. And not only that, it's also because of the chronic illnesses which women are predisposed to in their menopausal years. And needless to say, urogenital atrophy and increased metabolic syndrome and weight gain risk attendant with the hormonal disturbances. These are the basic principles we would give to any woman, particularly in and around midlife, because they worry about the redistribution of fat, the weight gain, which is unexplained. I have every woman coming to the clinic saying, என்ன ஆச்சுனே தெரியல டாக்டர் 2 மாசத்துல 5 kilo. But they would have forgotten, they might have been stressed with so many changes happening around that time, or they have not had time to exercise or not watch their diet. So the general rule of thumb is eat the rainbow, include more vegetables, go low on your glycemic fruits, have whole grain, have no processed food, or in fact, avoid buying any processed or ultra processed food. If you're animal protein person, take lean meat and be cautious to avoid low energy availability. The rule of the thumb is take calorie rare foods, but which can have in good amounts. So more fiber intake as well. So we all understood the macronutrients which are to be included: protein, calcium, fruit and veg, and diet for heart health, vitamin D, and the diet to reduce the weight gain. And tell people exercise alone will not cause weight loss. In fact, the WHO recommendation of 30 minutes for 5 days a week is for maintaining the weight. If you need to have a weight loss, 60 minutes per day for 5 days a week, which is 300 minutes a week with 3 days of strength training minimum for a menopausal woman if there has to be a perceived weight loss, which is what is to be recommended. What does protein actually do? It shuts off the hunger signals in the brain. I remember an endocrinologist telling once that advised women to take a sundal or something protein rich around 4 o'clock. Say they do not have very sumptuous dinner because that is the time there is adrenal fatigue. They find it very difficult to concentrate. The protein will shut off the hunger signals in the brain and help them carry on till dinner time, where they might have only a light dinner and not a carbohydrate rich meal. It helps maintain focus, facilitate serotonin and dopamine levels, which are happy hormones, helps to control the sugar cravings. Otherwise, you will go and binge on a pastry or a samosa, which is the time when people transit between places or feeling very sleepy. Necessary, very much necessary to build lean muscle, and as an important matrix for the brain to also protect bone density and for getting good quality sleep. Carbohydrates are not bad, but choose the carbohydrate judiciously. Take complex carbohydrates. So it is important to monitor not only the portion, but the type of carbohydrate. So don't choose very rich carbohydrate rich fruits. Fruits are better had as fruits, not as fruit juices. Fermented veggies, grains basically have a good mix of lentils, brown rice, and quinoa where they are not processed and have a good protein content. And important on the plate should be cruciferous vegetables like broccoli, Brussels sprouts, cauliflower. The moment I tell this, patients immediately ask, and it's a thyroid problem, what should I do? I'm not supposed to take it at all. Actually, no, you should cut down the amount of these brassica family vegetables, but broccoli is known to give good amount of magnesium, good amount of protein, and is an essential part as complex carbohydrates to provide fuel for the body as well. What about fats? We need healthy fats, and these are available from the sources which I have shown. Very important for brain function, immune system support, reducing the inflammation and joint cushioning. We see more of a women having knee pain, difficulty in walking, the gait gets construed, and they gain weight because they're not able to do the normal mobility. So it comes like a vicious cycle. So it is important from that point of view. So the basics would be increase your protein intake. The best way to be is consciously make sure you plate a portion of protein in every meal you take. You'd be surprised that we totally ignore that because we don't give importance to the macros as well. You don't go shopping for protein carbohydrates. You go shopping for foodstuffs. So understand which foodstuff gives you more protein. So place a protein portion in every meal you plate. So that is the way to increase the protein intake. Totally cut off sugar or limit the sugar. Get off the habit of having desserts after every meal, and increase the fiber intake by increasing the portion of uncooked vegetables or boiled vegetables and fruits and nuts and seeds. So beyond middle age, beyond the basics, we also need to look at the various micronutrients, which Dr. Aditi has beautifully plated before us, including the omega-3 fatty acids. I also want to tip in about the phytoestrogens, which have played an important role in the nutritional aspect of midlife and beyond. And flaxseed, sesame seeds, berries, apples, tofu, soya have very good amount of phytoestrogens. In fact, it has been proven that using tempeh, soya, a cup of soy milk every day is beneficial for the cholesterol levels, especially down-regulating the LDL levels, so as to provide a healthy heart. An important aspect is that soy products do not increase the risk of breast cancer. Soy products do not increase the risk of prostate cancer in men. In fact, it has been proven by studies that phytoestrogens in the form of soy milk help regulate the mechanisms better, and these are better taken as foodstuffs rather than as supplements. Resistant starches, this is again an in thing. I'm sure Dr. Pal will be throwing more light on it. It helps repair and rebuild the gut lining, reduces the inflammation in the gut, and causes a better microbiome in the gut. So the resistant starches are all our beans, legumes, lentils, our age-old varaka, the unripe bananas, steel-cut oats, not the processed oats, rice cooked and cooled, basically paraya sadam. Sweet potatoes. Sweet potatoes form a very good snack, especially if you boil them and grill them and a bit of seasoning. They form a wholesome snack. You don't need to eat anything with that. And the root vegetables. When I say root vegetables, people ask again, na diabetic, doctor, don't take rice and root vegetables. That will make your sugar level go up because they do not match each other with a glycemic load. If you're taking root vegetables, that is your carbohydrate. Do not have rice with that. So the resistant starch is a very important concept in maintaining gut health, especially for menopausal women, to avoid bloating, because menopausal and midlife women do complain a lot of bloating. So advise them to have the beans, legumes, and lentils during the daytime, and no starch lentils or beans or sundal beyond 4 p.m. If they have a nighttime sundal, that is when they have a lot of bloating. Whereas the sweet potatoes, these kind of things could be better off in the nighttime. So these are some ways we can advise our women to time the type of food as well. Micronutrients are very essential for age-related changes which cause impairment in their absorption and utilization. And because of the multiple medications they are in and the diet quality often declines, always take care of the dentition of these women. Our elderly women, especially who are diabetic, do not go to dentists every 6 months. And they lose their dentition very early. And if the dentures are not fitting properly, they don't use dentures. And believe me, the nutrition value of food drops significantly. They are deficient in all the micronutrients, and all that they can eat is semi-solid food, which does not give them any fiber, and hence ensue the problem of constipation, incontinence, bloating, so on and so forth. So every single aspect of their body needs care, and self-care is more important right from a young age. So these nutritional deficiencies, that last slide of Dr. Aditi is literally like a punch dialogue. Whatever you eat is a long-term investment for your further problems in life. So that is very, very powerful. Thank you. So widespread vitamin D deficiency, especially imagine our demented women or women living in old age homes or senior living, they will be devoid of sunlight, especially bound to certain rooms which are dark. That causes profound vitamin D deficiency. Inadequate calcium intake further increases risk of fracture. Low magnesium, the most common nutrient deficiency, leads to disturbance in sleep, contributes to more constipation, mood instability, and further worsens the osteoporosis. B vitamins deficiency affect cognition and heart health, especially if they are on metformin, they will be B12 deficient. Iron deficiency still possible, and it's a significant proportion, especially in the postmenopausal women, because of the gastritis they have, or because of occult blood loss, which they can have.
You hand up, ma'am?
Sure. Calcium has already been dealt with. I just want to, again, harping on the magnesium. It elevates hot flushes and improves moods. And we have a load of nutrients which are significantly rich in magnesium, especially don't forget the nuts and seeds. B12 and B complex for neurocognitive and cardiovascular development. Zinc for immunity and as a hormone modulator. And vitamin C's role in immune support as well as absorption of non-heme iron. Just a point on vitamin K2, synergistic cofactor for the calcium in the management of osteoporosis. And soya products, especially the natto, is very good in vitamin K. Omega-3 fatty acids has already been dealt with. And be wary of the thyroid deficiencies which can happen. But TSH levels which is increased could be a feature of obesity as well. So deal carefully with thyroid supplementation. Excessive thyroid supplementation in postmenopausal women itself could be an aggravating factor for osteoporosis. So be wary of that. Antioxidants, definitely in the nuts, seeds, and grains, increases the glutathione peroxidase, and important for thyroid function, reduces cancer risk. So these are the various interaction of the micronutrients, and they provide significant relief against bone density depletion. Magnesium supplementation reduces hot flushes, improves the quality and the quantity of sleep, and also reduces constipation. Omega-3 reduces depressive symptoms and the vasomotor complaints. B vitamins enhance vitality and cognitive function and energy levels. Zinc and vitamin C are important for boosting the immunity as well as wound healing. Cardiovascular risk reduction, mainly by looking after the vitamin D supplementation, magnesium, and a triple omega-3 along with the B vitamins. Cognitive and mood support, B12 and folate deficiency have to be addressed, omega-3 and magnesium supplementation. We have already mentioned this. These are some of the evidence-based studies which have been shown as important evidence how these micronutrients come in handy in the nutritional health of our midlife women and beyond, especially calcium, vitamin D, vitamin B complex, omega-3 fatty acids, and vitamin D again, and calcium. So these have been proven by various randomized controlled trials in postmenopausal women and systematic reviews. Dietary sources are very much superior to supplementation. Mediterranean rich diet, supplements only indicated for deficiencies, and we do not routinely monitor them. And practical recommendations for clinicians: take detailed history, lifestyle history, screen for risk factors, educate on balanced diets, individualize supplementation, and collaborate with dietitian and nutritionists, take their help. So menopause increases risk of micronutrient deficiency. Key micronutrients have already been enumerated. Assess, individualize, and customize intervention. And supplementation is not for all. Encourage food intake as the source for supplementation. Thank you.
Thank you very much, ma'am. It was a wonderful session.
Request the chairpersons to introduce the next speaker. Sahiti, can you share the CV of Satyanarayan?
Okay. Our next speaker is Dr. Satyanarayan. He is the professor and HOD of the Department of
Wales Medical College, ma'am.
I'm Dr. Satyanarayanan, working in Wales Medical College, ma'am. Working as professor and HOD of the Department of DVL. DVL means Dermatology, Venereology, and
No, sir, there was some problem in my sound thing. It's got muted. We welcome you to speak on the topic skin and hair changes and nutritional deficiency in midlife. You can share your slides, sir.
Good evening to one and all present here. Thank you for the opportunity given to me to present in this seminar. Actually, I'm very glad and very grateful to be one among the speakers here, because I'm little tense also, because some of my teachers are also here, some of my colleagues who have worked along with me, Hepzibah ma'am, who has invited me to give a talk in this program. It's a very great honor for me to be in front of this elite panel of members here. So without wasting any more time, let me get into the topic per se. So I'm going to discuss about the skin and hair changes which occur in women in midlife and beyond, and how much this is going to be attached to the nutrition. Not, it is actually, the nutrition part has been very elaborately spoken about by the last two speakers. So I'm just going to put a just on how the aging changes are going to take place in women post-menopause, and how much the hormonal factors are going to influence it, and what are the treatment options we give for these patients who seek treatment from us, from dermatologists. So the objectives of this presentation will be, I will be covering upon the menstruation and skin changes, skin health in women across the age groups, and the role of hormones in the female skin and hair, and skin, how it looks in the ages between 40s and above 50s, and role of the dermatologist for graceful aging in women. So the hormonal role in females will be, it's not only limited to the energy and the sexual functions, but also it has so much of relevance to the skin and the hair health. So it has a significant role in the barrier function, the sebum production, the skin hydration, the collagen and hyaluronic acid production. And understanding all these, the short-term and the long-term hormonal influences in women, will help us to formulate good skincare strategies, and also promote good skin health and hair care practices in menopausal women. So we know what the phases of menstrual cycle, how much like the estrogen is going to be supportive to the skin, how much is going to support the hydration and also prevent dryness, and also how much progesterone is going to be causative in certain conditions like acne and exacerbation of seborrheic dermatitis. So the skin health in women in 20s to 30s is going to be mainly influenced by other, not only by the hormonal imbalance, but also by the stress and the important part in their life, namely the pregnancy. So the hormonal imbalances is going to be taken care of by OCPs, but these are going to be only a temporary phenomenon. But again, the conditions which are happening in conditions like PCOS, namely the acne and seborrhea, is going to exacerbate once we stop the OCPs. And the stressful life transition is going to be associated with the increased cortisol levels, which will throw the patient into a pro-inflammatory state, causing exacerbation of certain autoimmune conditions like psoriasis, eczema, and hidradenitis suppurativa. And pregnancy, as we know, there's going to be increase in the alpha MSH hormone, which is going to cause the skin pigmentation, namely the cloasma and the vulvar and the areolar hyperpigmentation. And the pregnancy glow is going to happen due to the cutaneous blood flow. What happens when the patient goes beyond that age group? After 20s and 30s, when they reach the 40s, the estrogen levels are going to reduce so that the collagen and the hyaluronic acid production is also going to wear down. And also the sebum production is going to decrease as with the estrogen decline, which causes the skin to become more dry and prone for inflammation. And the cellular turnover, which is going to be again influenced by estrogen, will become slowed down, which will lead to altered wound healing and also delayed desquamation of the skin. And oxidative damage caused by other hormones, namely the other vitamins and micronutrients, which they already stressed about, is going to cause accelerated aging and skin carcinogenesis. So the skin and hair changes in climatic. Is this an underrated phenomenon or it is not cared about? Like most of the time when we talk about menopause, we talk about the vasomotor symptoms and all the other stuff. But the patient's perception about the skin and hair care doesn't happen to come in front. But there have been studies which have showed that about 72% of women were really concerned about the skin and hair in menopause, but they were least informed about the changes which are going to happen in menopause. So this highlights the need for educating women and healthcare professions about the impact of menopause in the skin. So the visible signs of dryness, the wrinkles, which we think usually is due to aging, has to be taken into consideration, and like how it's going to happen and how much efforts we are going to take in treating that has to be mentioned to the patient. And women are frequently judged based on their external appearance, the skin and hair in particular, as a sign of well-being, causing significant psychological burden. So skin, as you know, like it's more of an endocrine factory. So most of the hormones are going to either get produced or get metabolized in the skin, and that is going to impact the appearance of the skin in as the women ages. So in climacteric and menopause, there's gradual and steady decline in the sex hormones, along with the reduced expression of the receptors which are there in the skin. Apart from the sex hormones, other hormones like the thyroxine, cortisol, ACTH, and insulin-like growth factor are going to be related to the pathophysiology of skin aging in women and during menopause. We know about the source of sex steroids in young females and how do they get metabolized. So this diagram actually shows what are the sites of expression of the receptors for the androgens and the estrogens in the skin, and namely the sebaceous glands, the hair follicle cells, and the keratinocytes, where and all like they express the receptors for the hormones and how much these hormones are going to influence the appearance of the skin and the hair. That diagram put in a tabular column shows the enzyme activity where and all is going to happen, and the sex steroid receptors are going to be present in which all sides of the skin and the hair. So the hormones are going to have multiple roles in the skin. I'm just going to highlight about certain hormones, namely the sex hormones, and also the other hormones, namely the vitamin D receptors, and also the melanocortin, the alpha MSH All these are going to play a role in the skin differentiation, regulation of differentiation, and also inhibition of carcinogenesis, and also reducing the hyperpigmentation, which is going to happen in as they age. So the skin aging is mainly divided into the extrinsic and the intrinsic aging. When it's going to be extrinsic aging, it's going to be due to UV radiation, smoking, oxidative stress, the poor lifestyle habits, pollution, nutrition, etc. And the intrinsic factors, namely the age, genetics, ethnicity, sex, and the change in the hormonal status, is going to be causative for the intrinsic aging. So this shows the trends in the sex steroids in the climacteric phase and the menopause. There is significant decline in the DHEAS and estradiol as the women ages, but the dihydrotestosterone levels are going to be the same. So that is why we see females having more of acne and hirsutism even in the postmenopausal age group. Extrinsic aging is mainly characterized by the loss of structure components of the skin. Namely, if there is accumulation of the abnormal elastic tissue in the dermis, there will be poor elastic recoil, giving rise to easy bruising of the skin, sparse distribution of collagen and increased collagen degradation, which will lead to decreased resilience and poor wound healing again. And dysfunctional ground substance will lead to poor dermal hydration and dryness of the skin. And impaired proliferation, differentiation, and desquamation will lead to poor cell turnover and also decreased wound healing. And increased in the number of mast cells is going to cause increased tendency or reduced reduction in the threshold for itching. And flattening of the dermoepidermal junction and reduction of anchoring fibrils will lead to increased chances of injury to the shearing forces on the skin. And thickening of the vascular walls of the capillaries will lead to easy bruisability again. Again, intrinsic aging. Coming to the intrinsic aging, we talk about the changes which happen in the genes and stuff. So when we talk about that, it is mainly it's going to cause the loss of function of the certain cells. For example, there's going to be hypoplasia or atrophy of the epidermis. There is going to be increased fragility and vulnerability of the skin, and decreased activity of the Langerhans cells and melanocytes are going to give rise to increased chances for infections, graying of hair, and white spots, gutted amelanosis, which we get just as a hair grays, we get some white spots on the skin. And reduction of dermal thickness and decrease in the fibroblasts and atrophy of the extracellular matrix is again going to cause reduced strength and resilience. And the other functions, namely the decrease of the function of the skin appendages, is going to cause reduced sweating and loss of hair in the postmenopausal skin. And thinning of subcutaneous fat will lead to reduced insemination and make the patients prone for injury. And reduction of nerve endings will lead to disturbed sensory functions. So changes in the skin and hair structure with advancing age, the main thing which we have to note out about the common things which the patients are concerned about are the wrinkles, the collagen, the decrease in the collagen levels, and also the skin barrier dysfunction, which gives rise to reduced water holding capacity or increased transepidermal water loss, which we encounter, so that the skin becomes extremely dry and prone for itching. So like I said, skin moisture and water holding capacity tends to decrease as the patient is going to age, and sweating and thermoregulation is also going to be impaired. Sebum production, which is going to gradually decrease as the woman ages, and hair growth. Regarding hair, we mainly concentrate about the scalp hair, wherein there will be more of female androgenetic alopecia, which is more common as the female ages. And also, it is to be noted that there will be reduced amount of keratin in the postmenopausal hair. So when coming to the management of the skin and hair aging, we should customize the treatment and make it should be individualized and will depend upon the symptomatology, health status, and immediate and long-term health risks. And it also has to be the other things which have to be taken into account are the personal life expectations, availability of therapies, and expertise of the treating physician. So this is the common thing which the patients usually ask us, what is the daily skincare routine which we have to follow? So if the patient is going to ask such, we are going to advise the patient to have a daily skincare routine in the form which will help to protect, prevent, and cleanse and moisturize the skin. So in such a case, we have to advise the patient to have a good photo protection, usage of broad spectrum sunscreens with additional protection against infrared rays and blue light. So the infrared light source, I would say, it is mostly got through the cooking uh, from the cooking area. When they get exposed to the heat, that heat is going to emit good amount of infrared radiations, which is going to cause more photo damage to the skin, and also the blue light which is got through the screens. So our women are both working in the household as well as they're going to certain jobs wherein they have to get exposed to more of blue light. So filters which have additional protection for infrared and blue light have to be given importance. And based on when coming to the soaps, we prefer giving gel-based and bar cleansers for the oily skin, whereas we give a cream-based or lotion-based cleansers for the dry skin. And moisturizers which contain humectants. Humectants are the ones which will try to draw water from the atmosphere, namely substances like hyaluronic acid, urea, and allantoin are used here, and occlusives which tend to retain the water which is there already in the skin. Namely, the petroleum jelly, mineral oil, and lanolin will act as barrier to transepidermal water loss. Natural moisturizers are good for treating dryness in the photo-aged skin. The natural moisturizing factors here are the propylene glycol, sorbitol, urea, lactic acid, and hyaluronic acid. Ceramide-based moisturizers with additional peptides and probiotics are going to be helpful for the atopic skin.
So another 2-3 minutes, sir.
Yes, madam. So coming to the aesthetic non-invasive procedures which the patient seek treatment for is mainly for the sagging skin, the wrinkles in the skin, and also the dermatoporosis, that is appearance of prominent pores on the skin. So for that, we adopt to techniques like non-invasive RF skin tightening, microdermabrasion, and oxygen peel for the skin rejuvenation, microneedling for the wrinkles and the superficial skin resurfacing, and multipolar RF for skin laxity and cellulite treatment. And we have the latest Pico laser, which is an advancement of Q-switch NDR laser, which we use for treating sunspots and melasma. Systemic hormone replacement therapy has already been discussed about. It's not our territory. Like we usually take the help of gynecologists in giving hormone replacement therapy if the patient needs one. It has been said that raloxifene tends to increase collagen biosynthesis in certain studies, and estradiol patch and cyclic medroxyprogesterone acetate improves the skin elasticity. Isoflavones and phytoestrogens have already been discussed about. But in hair loss, there is no role for hormone replacement therapy. Topical agents which we use in skin anti-aging are the topical synthetic vitamin A and the retinoids, which help to diminish fine lines and wrinkles and normalize the skin elasticity and improve the skin tone and the texture. We use agents like adapalene and retinoid in treating such patients. We do chemical peels with alpha hydroxy acids, namely glycolic acid and lactic acid, which they stimulate the exfoliation of epidermal cells in the stratum corneum and also will lead to skin rejuvenation and also increase epidermal proliferation thickness and restore hydration by increasing the hyaluronic acid. Beta hydroxy acids are mainly for treating conditions like acne, which it has an additional anti-inflammatory property. The salicylic acid, which we use for acne, is ranges between 10 to 20%, and which we use for photo aging ranges between 20 to 30%. Vitamin C we use as a post-procedure treatment. We use it as a skin lightener along with other skin lightening agents. It serves as an essential cofactor in the post-translation processing of collagen. So we give vitamin C orally for patients coming with sagging skin and wrinkles. And also, it also reduces oxidative damage and thereby preventing breakdown of collagen to prevent further damage. Vitamin E, it is used mainly topically. It is not effective orally. So it's topically used in certain sunscreens, and it has an anti-inflammatory and anti-proliferative effect in the stratum corneum. It helps to maintain and accelerate the epithelialization and contribute to photoprotection. It is found to be useful in treating periorbital melanosis, the underlying dark circles which the patient gets, where it is used in conjunction with vitamin K, vitamin A, and vitamin C. So hyaluronic acid based formulations, we use it in the formulations of gels, creams, we use it in fillers, and also it is given in implants also to prevent wrinkles, prevent and treat wrinkles, and also nasolabial folds. It is used in anti-aging treatment, and also is a space volumizer. And it is useful for soft tissue augmentation by improving the skin hydration and collagen and is also stimulating collagen production. Hyaluronic acid alone or in combination with lidocaine shows a good promise in maintaining skin tightness and elasticity, and is also used in face rejuvenation. Other agents with debatable roles, the nutraceuticals which we use are the coenzyme Q10, alpha lipoic acid, beta glucans, lycopene, and oral ceramosites. I like to stress we use coenzyme Q10 mostly in patients who come for specific concerns of aging. Alpha lipoic acid is used little primarily in the reproductive age group when they come for conditions like PCOS. Oral ceramosites is a good option for treating dry skin. It's a newer agent which has come, and oral niacin is a good photoprotective agent, and it's useful in certain conditions like bullous pemphigoid, autoimmune diseases like bullous pemphigoid. Cosmeceuticals in the form of topical preparations in ceramides, nicotinamide, synthetic probiotics have more or less the same properties in treating dry skin, and also act as an anti-inflammatory and photoprotective agents. The other emerging systemic agents are the low molecular weight collagen. Other than the bovine collagen, which we inject as a filler, we use collagen as an oral drug given as 1000 mg daily dose, which will help to improve the skin, hair, and the nail health. It inhibits the matrix metaproteinases and stimulates the fibroblast function. Beta carotene, which is a provitamin A molecule, it acts as an antioxidant and anti-inflammatory and blocks ROS production. It is given in the dose of 15 to 30
Shall we
milligrams
wind
per
up, sir?
daily. Yes, ma'am. I'm going to finish.
Time up. Yeah.
Yes, ma'am. Probiotics will modulate the microbial composition and so useful in treating the atopic skin. Astaxanthin is used in treating many anti-inflammatory disorders, and it's also used for skin lightening treatment. Botox we do for wrinkles, usually. Fillers and threads, which we do for a sagging face, and it's also as a space volumizers. Hair changes in the climatic and menopause, apart from the androgen receptor mediated hair loss, there will be increased scalp dryness, sensitivity, and irritation, which will lead to dry scalp and itching. Texture and hair growth changes will also occur in hair. The hairs become shorter and finer, frizzier, or less shiny. So we give patients more of hydrating shampoos with conditioners. Sulfate-free shampoos are opted for here. Hair growth treatments, namely in the form of minoxidil, tretinoin, and hair peptides, are being used to treat hair growth or increase thickness. Volumizing agents like lightweight mouses and sprays are being used to add more bulk but not adding more weight to the hair. Melanin and skin aging. Melanin is a good component of the skin which will help to add more photo protection and reduce the incidence of skin aging. That is why people who are dark will tend to age more later compared to people who have a fair skin. So all these points have been put forth here in the melanin skin aging. So coming to the last two slides, the take-home points here are the skin aging is a complex biological process influenced by multitude of intrinsic and extrinsic factors. The major perceived risk factors are unhealthy eating habits, less exercise. All the importance of nutrition has already been stressed upon. Coupled with that, we have to add dehydration as one of the perspective, and other disease conditions like diabetes mellitus and other diseases. The patients are on drugs for other systemic diseases. Sleeping habits, particularly, which is becoming more and more worse in the coming days, is also playing a major role in the extrinsic aging. Anti-aging medicines encompasses lifestyle changes, hormone replacement therapies, antioxidants, and vitamin supplementation. And it has to be customized and tailor-made to each and every patient according to their needs. And there's no proven effective product that completely eliminates the symptoms of aging in skin and hair. But a combination of these with a better lifestyle will help to reduce or slow down these symptoms. Thank you, madam. Thank you for giving me this opportunity to present in this seminar.
Thank you, Dr. Satyanarayanan. On behalf of Dr. Geeta and myself, we thank the organizers for giving us this opportunity to chair this session. Thank you.
Thank you, ma'am.
Meena, can you
Thank you,
introduce the
chairperson.
next session chairperson?
Yes, ma'am. Thank you, chairpersons and the speakers. Now I would like to introduce the chairpersons of the next session. And as we are running on time, shall we take the MCQs at the end, madam, with the permission of the
Yes,
president,
Amma.
or shall we move the MCQs?
Meena,
Dr. Meena, there is
Madam.
a question from Dr. Pal. He's asking regarding the HRT. Can anyone of the seniors answer it?
Madam has answered in the chat box, madam. Shanti ma'am has answered in the chat box. Thank you, ma'am. Shall we proceed with the MCQs or with the next session, Shanti ma'am?
Next session.
that is the protocol. Finish up the MCQs. Because then only they'll have time
Okay.
to correct. Otherwise, we will not have time.
Okay, ma'am.
Yeah, finish up the MCQs.
Yes. Sahiti, can you please
Yes, ma'am.
post the MCQs faster?
Yes, ma'am.
Request everybody to take part in the MCQs.
Panelists cannot take part in the
Yeah,
quiz,
it's
ma'am. Only delegates can take part in this quiz, ma'am. I request Meena ma'am to read out the questions.
Yes, yes. Can you post the questions?
Yes, ma'am. It was displayed, ma'am.
yeah.
Yeah, first question I saw. Second one.
No, you have to finish up the first one. So which of
We
the
will.
four-
Yes,
Yes,
can you
ma'am.
please post the first question, Sahiti?
the first question, Ma, which of the following is the
Sorry.
most appropriate daily dose of vitamin D supplementation recommended for postmenopausal women over 70 years of age? 200 IU, 400 IU, 600 IU, 800 IU, 1000 IU.
5 more seconds. Time up. Second question.
A postmenopausal woman presents with fatigue, peripheral neuropathy, and cognitive slowing. Which nutritional deficiency is most likely responsible? A. Vitamin D, B. Calcium, C. Vitamin B12, D. Iron, E. Omega-3 fatty acids. Single choice answer. Salti, just have a watch on the time.
Next.
Sahiti?
Question.
Yeah, next question.
Next question.
Yes. Third question, which dietary pattern is most strongly supported by evidence for improving cardiovascular and metabolic outcomes in postmenopausal women with chronic metabolic disorders? A. Paleo diet, B. Ketogenic diet, C. Mediterranean diet, D. Atkins diet, E. Carnivore diet. Single choice question.
Five more seconds. Time up. Fourth question.
Fourth question. Which of the following is a common symptom associated with magnesium deficiency in postmenopausal women? Single choice. A. Joint pain, B. Osteopenia, C. Muscle cramps, D. Visual disturbances, E. Anemia.
5 more seconds. Time up. Fifth question.
According to recent studies, what is a major concern with routine calcium supplementation in community dwelling postmenopausal women? A, it causes vitamin D deficiency. B, it increases the risk of fractures. C, it leads to excessive weight gain. D, evidence of fracture prevention.
Insufficient.
Benefits insufficient. It significantly increases iron absorption.
Five more seconds. Timer. Yes, ma'am.
Thank you, Sahiti. Now we move on to the next session. Somebody has opened 2 mics. Please close. Now I take immense pleasure in inviting our chairpersons for the next session, Madhini Madam, Teacher of Teachers, who is the past president of OXI, and Dr. Ramani Rao Ma'am. Madhini Ma'am was retired professor, HOD, Department of Obstetrics Gynecology, Madras Medical College, former director, IOG EGMO, life member, IMA OXI IMS ISOPAP, OXI Achiever Award, Kausal Acharya Award, IMA Lifetime Achievement Award, has been a UG PG teacher for more than 45 years, examiner in various universities, had been an advisor in UPSC, given orations, has been a chairperson speaker in national conferences, presented various papers in national and international conferences, including FIGO, contributed chapters in OG books, interested in high-risk pregnancy, medical education, and traveling. Dr. Ramani Rao Ma'am, she is has got the Best Doctor Award from MGR University in 2012, life member in FOXI, OXI, CMS, IMA, ISOPAP, faculty in National International Forum, senior consultant running adolescent clinic, menopausal clinic at Ambattur. Over to the chairpersons to introduce the speakers, Dr. Palniyappan Manikam sir and Shaini Surendran. Over to chairpersons to take over the session.
Good evening. It's indeed a great pleasure to be the chairperson for this session. I thank the past president, Dr. Hepzibah, the present, Dr. Shanti, and the vice president, Dr. Premalata, and the Chennai Menopausal team for giving us the opportunity. Now let us go to the topic per se. I have heard Dr. Pal talking many times. It was very interesting, informative, as well as enjoyable with all those anecdotes. And Dr. Palniyappan Manikam is a consultant gastroenterologist at Sacramento. He's the chair of the Research Committee, Internal Medicine Residency Program at Wayne State University, Michigan, Representative Fellowship Council of Beaumont School of Medicine, Royal Oak, major professional societies, American Medical Association, American Gastroenterological Association, American College of Gastroenterology, American Society of Gastroenteroscopy, American Association of Study of Liver Diseases, and it goes on. He's a resident physician fellow of the Department for Gastroenterology, Hepatology, Oakland University, William Beaumont School of Medicine, etc., etc. So anyway, most of you must have heard him. So I don't think he needs much more than this. Dr. Palniyappan Manikam. Let me, my co-chairperson, Dr. Ramani Rao, kindly introduce Dr. Shaini Surendran,
Yes,
the sports specialist.
Yes, ma'am. Dr. Shaini Surendran, she's got a very impressive lineup in her CV. She's an accredited sports dietitian, preventive health nutritionist, level 2 chianthropometrist, and lecturer, author, speaker in various forums. She's holding honorary positions in the member of Board of Studies in Women's Christian College at Madras University, Association of Sports Nutrition and Fitness Sciences, former member FSSAI Working Committee on Sports Supplements, former chairperson of the website team, Indian Dietetic Association, former Board of Studies member, Tamil Nadu Physical Education and Sports University. She is specializing in sports medicine, and there is a long lineup again for her in her CV. I mean, there's no end to it. She's there everywhere, wherever you can see nutrition and sports. So we welcome this dialogue between Dr. Paul, and maybe it's going to be a very hilarious session. Let's hope so. Since Dr. Paul is there and Dr. Shiny Surendran, please take up this session.
Good evening, everyone. Good morning to Dr. Pal. Thank you so much to Dr. Premlata and all the office bearers for having us here. It's such an honor and privilege to be part of this meeting. Dr. Pal has joined us from Tennessee, and is that around 7 a.m. there?
8:30.
8:30, yeah. Okay. Okay, fine. So I have a request. Can I share the slides? Are you able to see my screen? I just want to quickly share. There's one. So with Dr. Pal around, we definitely need to have some humor. Dr. Pal, are you able to see the slide?
Yes.
Okay. So if you notice, this is what menopausal women go through. And being a gastroenterologist, and you have won the hearts of so many people with simplifying very difficult concepts and then putting it across. Even yesterday, I had a client who said, it's because of Dr. Pal, my very stubborn husband made changes in his diet. So this was a 60-year-old person who came and shared this, and she wanted me to communicate this to you. So Dr. Pal, you have no clue how you have changed people across the globe. Thanks so much for being here. And what do we do about the women who are trying to do their exercises and they're going through a lot of bloating and flatulence and all the gastric issues?
Thank you, Shani. You're wonderful. We have met so many times, and this is a wonderful pleasure to present and discuss what we deal with in terms of nutrition angle in front of these stalwarts. So thank you for having me here in this wonderful conference. So let me tell you my experience with postmenopausal women as a patient. I can clearly see a difference between US born 50 plus or 60 plus patient versus an Indian born 15 plus patient who are moved from Chennai to or India to US. So because I do screening colonoscopies, and when in the United States, any patient who turns 50, we get screening colonoscopy done to prevent precancerous colon polyps, to remove precancerous colon polyps. So when they come, it is very clear that when an Indian patient comes, there's always some kind of precancerous colon polyp. When a white woman comes, the likelihood of the colon polyp is less. And the whole physical profile, when they come 50 plus, 55 plus, there is always hypercholesterolemia, always hypertension, and pre-diabetes somewhere there. And their body fat percentage is easily more than 30. But it is on the contrary, if you look into the white women, it's only around 20 to 25 most of the times. It depends upon the location where you practice. I practice in California most of the times. In the United States, there are two wide varieties. Either they are very healthy or they are very obese. In California, they are very healthy because it's a blue state, it's a liberal state, and it is a relatively sunny state. So when you look at these healthy people, what they have invested time is investing in getting the body fat percentage down right after pregnancy at the age of 25 years of age. So what I see in my practice is when I take history from these patients, they do not have any gut health problems at all most of the times. But the same contrary, if you go and see ask Indian women, there's always bloating, there is always heartburn, and more importantly, constipation is more prevalent, at least in California where I practice. So as research suggests, there is also age-related decline in the number of good gut bacteria in the large intestine that we are seeing as well. So all put together, I think the long-term investment of metabolic health should happen at the 25 years of age so that that woman can actually have a good menopausal experience when the transition happens.
Okay. So the biggest challenge is, in theory, we all know what to do, but when it comes to practice is the problem, right? So when we all see our clients, we give a whole bunch of recommendations, send reminders through WhatsApp, call them for follow-ups, all these things happen, but then, it fizzles out. The motivation, the consistency, all that is a huge challenge. So what exactly do you think has really worked when you interact with clients? Like, what are the tips and tricks? Because, they're going through insomnia, they have hot flushes, they have a whole lot of anxiety, palpitations going on, there's itching, there's hair thinning, the vitality is going down, there's a lot of loss of collagen, and, there could be double chin, there could be a major changes, and they're going through this. And how do you even interact or communicate this across to help them stay consistent?
So in my experience, I have failed significantly in implementing exercise for some reason. Exercise has never been a part of the treatment regimen that they adopt, but they are very open to dietary changes. When I say dietary changes, I cannot remove biryani out of their plate. If I remove biryani of their plate, then the patient is removed from my list. They will not come back again. So what has worked for me is in my practice, as you know, Shani, I've been involved in this time restricted feeding as a part of research in Stanford. So I implement time restricted feeding to all my patients, mainly menopausal women. And I feel like the power of circadian rhythm itself will reset the hormonal disturbances at least 40 to 50% of the time. But they are, for some reason, Indian women are very consistent with the time restricted feeding because they start seeing changes right away. That was one of the most important thing that I encountered, Jenny.
Okay, okay.
How
Thank
about
you.
how about in your practice? What do you do?
Okay, so it's a lot of counseling, and we have to set the context right at the start. And I've been through menopause. It all started at 44 with perimenopause, and then 2023 there was one fracture, and then 2024 was another fracture in the metatarsal. So plantar fasciitis, name it, every possible, and of course the confidence also kept going down as I was also facing hair thinning. I was shedding more hair than my dog. So that is what was happening. So you know how a woman feels, like, the way she looks, or else the confidence with which she carries herself can really significantly go down, right? So main thing is to constantly remind ourselves, and also when the trainer calls up and says, please turn up for class, come to the gym, and there's someone or the other who's constantly pushing and motivating, and then also to set sustainable goals. I think that's the most important thing. And these are some
But
of
see,
the.
see, Shani, I'll argue from a doctor standpoint. Okay, so there are
Sure.
all doctors in the group
Yes,
here.
yes. All the senior doctors.
Okay, so we all senior doctors. No, we do not have the time to sit together with the patient and then explain and then follow up in terms of the exercise and everything. Correct?
Yes.
When you call the patient, when you follow up with your trainer, do you think they are adopting, or what is the profile that they adopt and what is the profile they don't?
Okay. So the thing is, it depends on how serious they are. So in case the doctor has said, you have a problem with your knee, and then you might need a knee replacement, and then they're very scared and they don't want to undergo a surgery, then they will really focus and get this thing sorted, right? They
So
will
you're telling us that we
plunge
should
into
scare
action.
the patient to the
I
maximum.
don't, the doctor does. And then the doctor sends them
That's
to
what I'm saying.
me. So that's what happens when the reference comes from the doctors. We are constant touch with them, with the referral physician. And then we also break it down into smaller steps. So we have a team of 10 dietitians. So we are constantly putting them in a WhatsApp group and then constantly calling them, and then emphasizing on, breaking it down to simple steps. So this month focus on water intake, or else it could be for a week or so, and then gradually extending it. So you give challenges for 30 days, 30 days, 30 days, and then a lot of things, meal timings, stepping up the protein, bringing in the omega-3, and all these micronutrients which are there. So I understand you doctors are very, very busy. In fact, we have doctors as clients, and we know the kind of stress that all of you go through. Absolutely. So I think that's when we need the allied health professionals. We need to work as a multidisciplinary team, the physiotherapist, the fitness professional, and of course the dietitian, right? And one more thing that I also want to know is getting the protein is a huge challenge. So would you want to do a comparison with what is happening there back then, Indians in the US? And over here again, see, if they're going to eat too much of sundal, there's a lot of bloating and flatulence. And this is one of the biggest challenges. And strength training, there are some, as you said, there's one segment which will do it. They'll do what you say. But then there's this other segment that says, I don't want to have bulkier muscles. I have this taboo. I don't want to enter the thing. I'm okay with walking and yoga. All these challenges come up. So how do we go about doing it? And also the gut and the, exercise, the connection between how gut health plays a big role. The gastric motility and constipation being a big issue, a lot of things get resolved when they actually stay very active. So, would you like to throw light on this?
See, protein requirement is one of the most critical thing for preserving the muscle mass, what we have already, as you know. What is happening from a gut standpoint is, we have done multiple research studies in terms of what is the right amount of protein to preserve the existing gut bacteria. We don't even have to increase it, just to preserve it, right? It depends upon ethnicity as well. Everybody is focusing too much on protein over here in the US. They're just going crazy, 2 grams of protein per kilogram per day, or even more than that. What we are finding out in the research in Stanford is that the protein requirement is based on ethnicity. So for Indian community, we have a study called Masala study, which we talked about briefly before. Masala study is where we analyze the metabolic syndrome profile in a patient from Southeast Asia, which will include India, Pakistan, Sri Lanka, Bhutan, Nepal, Philippines, who have been in the United States for the last 25 years. When you look at the metabolic profile and we look at the stool analysis, it is very clear that the protein supplementation has been overhyped in this Indian Southeast population. But at the same time, they are not even meeting the normal requirement. That is the most important thing.
Yeah.
That is the most important thing. So we don't have to go really high on, 2 grams per kilogram, but at least that 1 to 1.2 gram per kilogram should be met somehow. The reason for that is that the studies what we are dealt with shows that when the minimum protein requirement is there, the gastric motility and the intestinal motility is being preserved. So the most common complaint when you increase the protein is constipation. And the reason for that is the gut motility has not seen this much amount of protein ever in their life. So the immediate response for the gut is to slow down. The peristalsis will slow down. And it is just that initial hiccup that we have to come over, where either you increase the fiber, you increase the water, or you decrease the dosage of the protein. Then the body gets used to it. Then the body is absolutely loves the protein intake. Exercise helps to build muscle mass. Protein will help to preserve the muscle mass and also help in the muscle growth. Both of them help to increase the short chain fatty acids, butyrate, propionate, and acetate in the large intestine, independent of dietary intake. So there were 2 groups of patients that we dealt with. One is we said you eat whatever you want, don't need a balanced diet, but just make sure that the protein intake is there. We made sure that the other group had balanced diet, carbs, proteins, and fat, and they also had the same amount of protein intake. What we found out was independent of the dietary intake of other macros, just the exercise part alone improved the short chain fatty acids in large intestine. So that is one of the most important finding which we have to adopt and then try to implement in our patient population, where diet may not be the only solution. Exercise might have to be a part of it as well.
Absolutely. Absolutely. Thanks for sharing that, because there are a lot of people who don't drink adequate water, and then, eating. So vegetables வந்து ஊறுகாய் மாதிரி இருக்கும், ஒரு பக்கத்துல இத்தினூண்டா இருக்கும் இல்லையா? So as you always say, the plate method, அதை வந்து reverse பண்ணி if we start eating, so the vegetables are
I'll share a story here. I mean, it's maybe good for all the doctors to listen as well. So, other doctors, what I promote in social media is to increase more fiber. Okay.
Yes.
So I went to a marriage in my native village, Karaikudi, and there was this, I introduced this method called reverse banana leaf method. I said, you put the rice on this side and the other side, and you put the fiber, all the vegetables on this side. வெஞ்சனத்தெல்லாம் இந்த வச்சு வச்சிருங்க, ரைஸ் எல்லாம் அந்த சைடு வச்சிருங்க அப்படின்ட்டு நான் சொன்னேன். Then I asked the guy who was serving as well that do like that. He went to his master chef and he said I was a cuckoo. And then the master chef came, அப்பா உங்களுக்கு என்னப்பா வேணும்? சாதத்துல அங்கே போட்டிருக்கேனே, வெஜிடபிள்ஸ்லாம் இங்கே வச்சிருக்கேனே அப்படின்னு. அப்படியாப்பா, ஓகே இங்க வைங்கப்பா, வெஞ்சத்தை இங்க வைங்க, ரசத்தை அங்க வைங்க, சாதத்தை இங்க வைங்க அப்படின்னு சொல்லிட்டு நான் உட்காந்துருக்க சேரை இப்படி தூக்கி இந்த சைடு போட்டார் அவரு.
Okay.
It's a true story. This happened. That's how much amount of carb intake is compromising the fiber intake because of that's how we grew up with.
Yes, yes. In fact, what we need to have is like at least like half a kg of vegetables, or we'll say minimum 300 grams, minus the roots and tubers. So, urlakarangu, chenakarangu, chepangarangu, those are things to be avoided because it's as good as eating rice. But then to have a lot of the gourd vegetables and the beans, the string beans and the field beans and, the cabbage and cauliflower and all of that. So, this is how a plate, these are the recommendations that we usually give. And on top of it, we also definitely check whether the client has any food intolerance. So would you like to discuss about lactose or gluten intolerance? Because this is another major challenge. And one more thing is also IBS, and also during perimenopause and menopause, how do you even differentiate that this is IBS or else it's because of the hormone, imbalances that's going on in the body?
The IBS is a part of the hormonal changes. So that is not a separate condition in the perimenopause period. But the problem is when they have GI conditions before the menopause, the presentation is more severe. So that is where the problem is. So what I tell my patient is that before hitting menopause, we really need to increase the GI strength. So which means that, a minimum of 25 grams of fiber per day and one fermentation food per day, and making sure that, the sleep and physical activity is there. In my practice, if they hit menopause and if they have GI symptoms, to be honest, it's very difficult to follow, very difficult to treat. So we recommend hormone replacement therapy. And the reason that I ask in the group how often people adopt hormone replacement therapy is in US, they don't adopt at all, especially Indian women. They think that doctors are making money with hormone replacement therapy. And this is an absolutely a shocker where only 20% of people actually accept hormone replacement therapy as a treatment. And the other thing is overexposure to unwanted social media information where hormone replacement therapy causes much amount of cancer and all those things. Is you will not believe that I will tell them no matter how much amount of medication that I give you, your symptoms are not going to get better unless you go on HRT. That doesn't happen at all. So that is a tough challenge that I face. How about in your practice, Shaini, in postmenopausal women, when you say that you have to eat this, will they agree or will they ask questions to you?
Okay, so yes, they would definitely have some non-negotiables, which means in coffee la kaiya vekkadinga, in tea la kaiya vekkadinga, enakku oru murukku venum, or I need some sweets. I'm used to this for the past so many years, and please don't remove that. In fact, I remember one client who said she used to watch TV, and when the entire household goes to sleep, she's a Punjabi, and she said after everyone goes to bed, she goes to the kitchen and from the shelf, she'll take a bottle of whiskey and then she'll sit and drink that while watching TV. And she said, you better adjust the calories to accommodate the 2 pegs that I want to have every single day. So it is part of her culture, and drinking was not taboo. And she, in fact, enjoyed it like every single day. So I was quite challenged that way. I've said, if you're going to drink alcohol, it's going to definitely affect the metabolism. And she was around 55. And she said, I don't know what you will do. So in the Mari request could varo. And
But drinking among postmenopausal women is not common in Tamil Nadu, correct?
A lot has changed in Tamil Nadu.
I see.
Yes.
I see.
Yes.
I see.
In fact, there's also
See,
recreation.
we did a study. We said that 1 ounce of alcohol decreases 2% of the beneficial gut bacteria. Bacteroides is one of the beneficial gut bacteria. Bacteroides fragilis, and the amount goes down significantly, even with the social drinking thing. So that is something that we were
Exactly.
involved in.
And the calorie consumption. So the moment they're going to drink alcohol, the hunger pangs, the sugar's going to drop and they will end up eating more. Your eyes are bigger than your stomach and they end up ordering quite a lot and they're constantly eating. So we are seeing that in the urban women. They're drinking quite a lot. And the alcohol again is not actually helping. It worsens the hot flushes. So Dr. Pal, one more thing is there's a lot of, the narrative in social media these days, if you see, is a lot about inflammation, insulin resistance, and we know in perimenopause and menopause how this is actually quite exaggerated, right? So how do you deal with that in your clients there? Because here the carbohydrate is so high, so we would always recommend a low carbohydrate, but then fill the plate with vegetables, non-starchy ones, and protein in every meal and every snack. So a meal would be like close to 20-25 grams, and then a snack would be anywhere between 5 to 10 grams of protein. So, and we'll also teach them how to have it, because we also have vegans here, lacto-vegetarians, and one pradosham will be there, one ekadasi fasting, and all that will come. So what are your recommendations? See, this is the meal plate that we usually recommend. So that's why I wanted to show you this. Half the plate full of vegetables. So it can be soup, salad, tair pachadi, tovayal, or it's a sambar filled with vegetables, any of that. So half the plate of vegetables and the other quarter, if you see, protein and starch, whole grains. Yes.
What I see here very commonly is gluten sensitivity among postmenopausal women. I think I shouldn't say postmenopausal, I think from 40 plus. So I see a lot of NRI community where they were born, brought up in, let's say, in Tamil Nadu for the last 20, 21 years. And then they moved to the US, either they got married or they have a job over here. And then the symptom starts around 40 years. So there is a reason behind it. There are studies that shows that when a patient is migrating from one area to another area, the gut bacteria changes, and the malleability also depends upon what kind of environment they are in. So I'll tell you one example. So right now you are in Tamil Nadu. A girl is around 21 years of age and being exposed to rajma, sundal, rice, curd, rasam, sambar, that kind of a gut bacteria, and then you transfer that patient into US, and you was getting exposed to pizza, burger, nachos, mayonnaise, noodles, you name it. It's not because they don't cook at home. It's just that the life gets really busy that they have to get exposed to these kind of fast food. What happens is that it just takes only 22 days to change the gut bacteria into the local environmental exposure. This we have seen multiple times in patients who are in Japan. They are able to handle sushi very well. But the same Japanese patient, when they go to US, and we are giving sushi, which was in the US-based sushi, they're not able to handle it. And it is very clear in terms of the gut bacteria. So migration of the Indian community all over the world is a problem as well. What is happening in this angle is that when the gut bacteria changes, they don't develop celiac disease. Celiac disease is you are immunologically sensitive to gluten, which means that you have autoantibodies in your body, which damages your small intestine because your immune system is congenitally developed to you don't have you develop antibodies to the gluten. But what we are seeing is called gluten sensitivity. It's called NCGS, non-celiac gluten sensitivity, which is a component of IBS. And that happens because of the gastric and intestinal motility is not being normal, basically. So there is a speed in which the intestinal motility happens, and that varies from a patient to a different patient. But that speed is dependent on the brain-gut axis. The signal that comes from the brain, the neurohormonal center, stimulates the intestinal motility at a particular speed. And that is why patient having one bowel movement once every 2 days, 3 days, right from the birth is completely normal for that particular patient. But when a patient has one bowel movement per day, and that changes into one bowel movement every 2 to 3 days, that is where we call it as constipation. We don't call constipation if you just have one bowel movement every 2 to 3 days throughout your life. And this change happens because of the neurohormonal change. And when that happens, the small intestine, especially the duodenum, is not able to handle it that frequently compared to the stomach, because stomach is pretty strong. So when the duodenum is getting exposed to the gluten, the first thing that they experience is bloating. So it's not because that excess carb, SIBO is also a part of it, small intestinal bacterial overgrowth is also part of it. But more than that, this gluten sensitivity is a huge thing in my practice. So all Punjabi people in my practice, the first thing that I say is no roti. only for 1 week, and they will see significant improvement. Then we will have to let them know that you don't have to go gluten-free completely. You may have to tweak your diet a little bit. That's what I do, Shani, in my practice.
Okay, okay. So we usually remove the gluten and dairy for sometimes, say 15 days, and then we reintroduce it. And there's also this kapli wheat or emmer wheat which is available, which has less gluten. And if someone loves, say, sandwiches and all that, we usually recommend sourdough. So sourdough bread, sandwiches and all of that. And then South Indians are very receptive, but here in Chennai, when we see clients like North Indians are also very happy to eat idli, dosa, idiyappam, appam, uttapam. And they are quite comfortable because Sunday they actually order a full meal from, say, a place like a Palm Grove or also Sangeeta, and then have sadam, vattakodambu, parapapudi and all of that. So there are some North Indians who are happy to eat a South Indian diet for 15 days, and we see a lot of changes. And good news is,
So I'll ask you from a doctor's standpoint. So, a patient is coming into the clinic, has abdominal bloating, postmenopausal woman. So they usually say that, dietitian, nutrition. What can they say, like a quick tip, like ME wheat, what do you say, kapli wheat or something like that?
Kapli wheat. KHAPLI, kapli wheat, which has less gluten, or it's also called as emmer wheat, EMMER. So the ancient wheat is actually spelt SPELT, and there have been a lot of changes. So we had diploid wheat, triploid wheat as well as tetraploid wheat. So now we have hexaploid wheat. Now these were developed in order to have weather resistant, pest resistant produce and support the farmers to have better yield per hectare. But then this doesn't suit some of our gut. And then we do see a lot of NCGS in our population as well. So we do a nutrigenomics test, or else it could even be just an elimination diet for 2 weeks. And then we reintroduce back everything. So the biscuits and the bread and chapatis, wheat, dosa, upma, everything comes back. And then they're clearly able to see. So we make a note in the food diary. And then that's how we make the client understand constant inflammation over a period of time can also lead to autoimmune disorders. And you don't want to go that way with leaky gut syndrome and all of that, right? So these are some of the probiotics. Do you approve all of this? The Paraya Sadam, Pachadi.
Yeah, of course.
The
Curd, the
Solipadi and
kimchi. So the idea behind this is that, like we have 100 trillion bacteria in the large intestine. So the idea behind this is not to give just one version of the bacteria a lot. So there is no point in giving 10 billions of Bacteroides fragilis. That is much less beneficial compared to giving 2 billions of 5 different varieties. So that is the angle. And then I don't believe in synthetic probiotics at all. I think practice in Tamil Nadu really needs to change, where we give probiotics for everything. Please save your patients money. It is not going to work. There are only 3 indications that probiotics work. This is inflammatory bowel disease, pouchitis, Clostridium difficile colitis, where you are developing, actual inflammation in the colon. And the third thing is certain part of IBS where it is extremely resistant to all kind of dietary interventions. And that is also very questionable. It is not grade A recommendation. But if you look at a doctor's prescription, there's always probiotics. It comes with a problem as well, where I had a patient who had uncontrolled diabetes. Okay, so him A1C was 12. And of course, any patient with a diabetes also have an immunocompromised state because the immunity level doesn't work. So they were exposed to sepsis, and they got an infection. And the culture grew the probiotic that the patient was taking, because the probiotic is an active bacteria. So which we are really shocked, and it does come with some side effects as well. So the idea behind this is whatever you showed, Shani, yes, you have to include in a multiple variety rather than synthetic probiotic.
Okay. Thank you for sharing that. And one more thing is about time restricted eating. What exactly do you recommend? Because there are some who wake up quite early in the morning, say at 4, and then they will be quite hungry. So would you recommend a breakfast and lunch and then skipping the dinner, or delaying the breakfast and then, the 16:8 is what we usually recommend, right? So what is the protocol that you recommend to your clients? Because weight gain is imminent, and how do you handle that?
So this time restricted feeding will not make you lose weight. You need to really tell your patient upfront, this is not for weight loss. If it is weight loss, it will happen only in the first 2 months because it is all water retention. It will go away. Time restricted feeding, what it does is it just resets your circadian rhythm to a point, at least you can bring it back of the abuse that we have done in the past. In the studies that we have done so far, I was involved in, Dr. Sachin Panda is my guru, so you can check him out as well. He's from Stanford, UCSD, San Diego, and I was involved in fatty liver research with him. So one thing we found out was minimum 12 hours rest is needed for the gut to repair. So minimum 12 hours is needed. And maximum 16 hours is where the benefit actually happens. Beyond that, in all this autophagy and all this thing of extended fasting is not really proven. So I don't encourage that in my patients that much. So I say minimum of 12 hours. And every patient is different. So we have to individualize the fasting regimen according to them. Sometimes if what I say is, if you're not feeling hungry in the morning, you don't have to have breakfast. 2 meals a day is completely okay. What we have seen is that if you keep on stimulating your insulin doesn't like it. So let's say you talk about 10 grams of snack in between lunch and dinner. What we say is you can include that snack along with either lunch or dinner, and you just let the snack go. We're not saying no to the snack, we just the timing, because the more rest that you give to insulin, the better it is, as you see with any recovery. But some patients are really hungry in the morning. We are completely okay for them having the breakfast. So just like individualized. Certain studies also say that skipping breakfast might not be the best outcome or long term. And if you really look into the study, it is not practically applicable to our patients in the community. That is what the problem is. That was done in a nurses' health study, NHS, which is like white people with less carb. So you cannot translate the exact same thing to our community and then say, so, you have to eat breakfast. That is not the right thing to do.
Absolutely. I agree. Because there are some who don't eat breakfast, but there are some who insist on breakfast. I think eating a dinner much earlier would be the most practical thing. So anywhere between 6 to 7, if they are done with it, and then they maintain at least a 2.5, 3 hour gap before they go to bed, the sleep is also pretty good. And that's one of the main reasons why we recommend that. So I'm just sharing a slide to show foodstuffs that will really help in sleep. And also chamomile tea helps. And then staying away from gadgets at least 2 hours before sleep. And magnesium glycinate has also been very helpful. Magnesium spray is available as well as oil. So that's another thing. So are there any questions from our esteemed guests here? Meaning, is there anything that you might want to put in the chat? I'm just going to quickly run through this. Yeah, insulin roller coaster. So as Dr. Pal mentioned, time restricted eating, and then each client is different. We just have to look at any takeaway points, very practical tips for a woman going through perimenopause and menopause, Dr. Pal.
I think, in my opinion, I think we should just make sure that strength training is a part of that is what I would say. That is what one of the most important tip, especially Indian women. I think all the doctors who are on the call, I think whenever you see any client, you just let them know that, sign up with Shiny or sign up with anybody else, but make sure that you lift weights. I always say you can lift, it could be like 1 kilogram dumbbell, 2 kilogram dumbbell, or even the head weight of your in-laws.
There you go.
Dr. Shiny, the time?
Yes, we are wrapping up, ma'am. Yeah. 2 minutes and we wrap up. Yes, Dr. Pal. The head weight of in-laws. Yes. Anything else to add to the weight?
Late night eating is one of the most important thing, more than all this.
Yeah.
Late night eating of even healthy foods. That is one of the most thing that we have clearly seen, that it has a direct correlation.
So true. So true. So thank you so much for sharing all the inputs, things that you have witnessed there in your practice in California. And we will look up Sachin Panda. I have looked up already, but I'm sure there are so many studies also that you've quoted. Thanks a ton for being here. And if there are any questions, I'm going to hand over the space to the seniors.
In the chat box, somebody has written 2 questions. Protein, collagen, creatine, and fiber as supplements. Your thoughts, please.
Yeah, we do recommend creatine monohydrate for especially vegetarians, but for non-vegetarians, it doesn't seem to help. And even among vegetarians, there are non-responders. But there is a supplement protocol. You just have to, because we work with athletes, I primarily work with a lot of competitive athletes and all of that. And as they hit perimenopause, that's when we do this. But Dr. Pal, how about your thoughts? I would definitely consider B12, D3, omega-3 around 3 grams a day, and magnesium for bedtime, and also broad spectrum multivitamin, which will have some soy isoflavones. Over to you, Dr.
See,
Pal.
see, I prescribe fiber like anything to all my patients. You know, the average fiber intake is only 10 grams per day for an Indian man and a woman. Of course, men should have even more fiber, 35 grams of fiber per day minimum. So Isabgol husk is something available in India where we have to titrate the dosage accordingly so that the patient doesn't have the phenomenon of bloating. In the US, it's called Metamucil. It works beautifully. If you have any patients who have some US relatives, they could easily bring the Metamucil, which in my experience, I have both patients, India and the US. I think Metamucil works great than Isabgol on most of the patients. And so that is something that I would recommend for the doctors to actually as a take-home point. You could use it.
Yeah, okay. So we usually recommend supplements only if somebody's traveling extensively, but otherwise we always ask them to have like fresh fruits, vegetables, unpolished rice. You do have this mapla sambarasi and all of that, which comes with a lot of fiber. So that's another factor. But especially when people travel and if they're on a long car journey and all of that, they don't want to use the washroom, they're not drinking enough water. All of these things come in. So the fiber supplement helps a lot. Yeah, flax, chia, and sabja is another thing, which is also very helpful for hot flushes. Okay, anything else? Protein, again, there's whey protein supplements for pure vegetarians who are struggling to get their food all put together, or else sometimes even unflavored protein. And if they're lactose intolerant, we put them on peace protein isolate or else a plant protein supplement. Again, it's very subjective to the client's requirements. How about you, Dr. Pal? Is there anything that you might want to share?
Yeah, so I do whey protein isolate, which is less stressful on the gut. So there are three things. One is whey protein, regular whey protein concentrate. The second one is whey protein isolate. And the third one is hydrolyzed whey protein. So basically, it's just the different steps of whey protein where they're taking the milk and the protein degradation back. So in my experience, if you just ask them to take a protein powder, invariably Indian community have bloating. They will not be able to handle it at all. So an expensive version is the whey protein isolate. So that is one thing. The second thing is I have tried other alternate option is that let's say that Whole Truth is a good protein brand in India, but Whole Truth itself can cause bloating to a particular client. So you may have to try different brands, and one of the brand will definitely work for you. It's a painful process. And in India, they don't give free sachet as well. That's another problem. It's a big bottle. So that is another issue as well. So, but eventually, we may have to train our patients to focus on one little whey protein and just stick to it for the rest of the life, so that will be a good supplement. I'm big on protein supplementation as well.
Yeah, yeah. So if anyone needs supplements, what I use is Origin, which is a Chennai-based company. I work with the MRF Pace Foundation. I handle the cricketers there. And the founder's daughter has this protein called Origin. And if anyone needs sample sachets, please let me know. I'll be happy to send it across to Dr. Premlata ma'am's residence. And from there, she could always pass it on to you. Okay. That's a plant protein. I tried 8 different supplements, which was available across the country, and it tasted so bad until this Origin came into the market. So these days we have some more possibilities, but if anyone wants to try it, I'll be happy to send across some sample packets. Yes. So shall we wrap up this session? Thank you so much for this wonderful opportunity, Dr. Premlata, and every esteemed faculty here, senior members. Thank you so much. Dr. Pal, your little
Thank you very much.
spoken up.
Thank you very much, Dr. Pal and Dr. Saini, for your wonderful dialogue and giving the importance to the gut bacteria and the diet. Thanks a lot. Thank you.
Thank you, madam.
Thank you, ma'am. Thank you for coming.
Thank you, ma'am.
Bye.
Thank you, chairpersons and speakers for the excellent session. Now I request our Premlata ma'am, Vice President IMS, to close the session with a vote of thanks. Over to you, madam.
Okay, thank you. At the utmost, I just thank Dr. T.K. Shanti and Dr. Meera Raghavan, President and Secretary of this society, for made this webinar is very interesting and planned this thing. I thank Dr. Hepzibah, who has been instrumental in selecting the speakers and all the chairpersons. I profusely thank our chief guest, Dr. Anita Shah, and guest of honor, Dr. Sindhya Madam, for accepting and gracing this occasion. I thank all the chairpersons, Dr. Madhuri Madam, Dr. Nandita, Dr. Ramani Rao, and Dr. Geeta for the available time. I thank the speaker, Dr. Aditi. She has given the importance of all nutrition deficiency in postmenopausal women. I thank Dr. Dr. Satya Narayanan for his talk on nutritional deficiency in postmenopausal women, on skin and changes in skin and hair. I'm very happy that I could arrange dialogue between Dr. busy sports nutritionist Shiny and very important, famous medical celebrity, Dr. Pal, to have a dialogue amidst our webinar. I'm very thankful to Dr. Pal for joining the thing across the globe at the early morning. He has taken pains to join the webinar, and I'm very thankful to Dr. Pal. And I thank Dr. Shiny for his wonderful interaction with Pal and bringing out all the important points in this August audience. I thank all the delegates who have been present here to make this webinar a grand success. I thank the Master of Ceremony, Dr. Meena Mahalingam. I thank Dr. Shahidi, the shield person who has been instrumental in coordinating all these things. I thank all the one and all who has been involved in this webinar. Thank for the wonderful opportunity.
Kindly post the
yes, ma'am.
Sakiti.
Congratulations. Anbu Subaya has been the thing. Then Gomadi Madhyalaham, Ramai, they have got the prize. Congratulations for the thing. Okay.
Is from Coimbatore. So it's very nice. Congratulations, winners. Yeah.
My special thanks to Dr. Pal for joined from USA, Dr. Shiny for having interacted with him and brought him here to the podium. Thank you, one and all.
Yeah. Can we have a photo now? Kindly switch your cameras. I would request all of you all to switch on your camera, please.
Dr. Pal also to join the screen. Is left?
Yes, left. He must be very busy catching up in his work. Dr. Shiny is there. I think she is.
Shiny is there.
Thank you.
Okay. Yeah.
Yes, ma'am. I have taken few pics, ma'am.
Thank you, Sahiti. Always very helpful. Thank you very much. So we will meet again in the next program. Thanks a lot.
Thank you, Pa.
Thank you for the wonderful opportunity given to me.